Good morning. My name is Katarzyna Ochnik. I'm Mindry Poland. Welcome all dear professors. It's very nice to meet you here. And thank you for your time. We know that it's very occupied time for you as a healthcare professionals. And we believe that sharing here is very valuable to all of us as patient and healthcare. And we believe that it will bring value. I will pass to Professor Czufar, who will share with us, start and be a moderator in this discussion. So thank you for this role, and I'm passing to you.
Thank you. So hello everyone, welcome. It's a great honor for me to be able to host this discussion. First of all, many thanks to all of you who have decided to join this event and share your expertise with us. We are very grateful for that, and I think that I'm speaking for myself, Professor Owczuk, and all intensivists in Poland. Thank you very much once again. And I will start with a brief presentation of all of us here, especially our distinguished guests from abroad. So I would like to start with Professor Ziyong Peng. It's our friend from People's Republic of China. He's a professor of critical care medicine and anesthesia and the chair of the Department of Critical Care Medicine from the School of Medicine in Wuhan. Professor Peng has visited Poland recently. He was our guest in Poland last year. We couldn't imagine what would happen with the COVID situation back then, but now we are very happy to have you here with us. Thank you. Then, of course, another guest, Jean-Daniel Chiche, former president of ESIGM and a member of steering committee of Surviving Sepsis campaign, a full professor of critical care medicine in Paris Descartes University, and he's currently working in the medical ICU of Cochin University Hospital in Paris. And I would also like to give a warm welcome to Professor Radosław Owczuk, chair and head of the Department of Anesthesiology and Critical Care of Gdańsk University, and also a national advisor consultant to the Polish Minister of Health. So I myself, I'm also an anesthesiologist and critical care physician, and I'm a head of the Department of Anesthesia and Critical Care in Lublin University, and I'm also the head of the local ECMO center. So I think now what everybody knows who's who, I would like to give you the opportunity to share all the most important facts that we have learned during the pandemic. And I would also, and now I would like to ask Professor Peng to give a brief talk about his experience with the COVID-19 outbreak. Professor Peng, you're welcome to start. Thank you.
Okay. Hello, everyone. Thank you for inviting me. So I'm Dr. Peng from the Department of Critical Care Medicine, Zhongnan Hospital, Wuhan University. It's my honor to share my experience with you. Actually, we have learned a lot of the, from our patients in the last couple months. Today, my topic is what we learned from our COVID-19 outbreak in Wuhan. So actually, in the early stage of the outbreak, we need to prepare for the medical resources. So actually, the resources, including the medical beds, ICU beds, all the medical professionals are limited. So we need to mobilize the medical resources under the help of the hospital authority or under the help of the government, and we need to organize the new team for our patients. So especially we need to increase the ICU beds for our patients. The more ICU beds, the more patients will be saved. So actually, my approach is to recruit the anesthesiologist from our hospital. So actually, the ICU sites, the ICU beds in my hospital almost tripled during this outbreak. So difficult for us to recruit the intensivist, but we can recruit the physicians from anesthesia department. So actually, during this outbreak, almost the hospital closed down. So we can recruit the physician from other specialty. So my approach is to try to recruit the patients with the similar training with us. So anesthesiologist is the best choice for us. I know in Europe is the most of the ICU belong to the anesthesia, but here in China we separated. So for me, the anesthesiologist is the top priority for us to recruit. So actually, about the personal protection also is the top priority for our medical professionals. We need to prepare all the PPE, including the gloves, the gowns, protective shoes, and also the mask, including N95, goggles, face shield, and the hood. And also we set up the protocols for the precautions of droplet, close contact, and airborne. And also we have the protocols for how to wear the PPE and how to take off the PPE. Make sure everybody can follow the protocols. This is quite important for us. And also we monitor the ICU environment regularly to see how is any positive virus in the environment. So this is all important for our ICU professionals. So here I also talk about a little bit the general features for our patients in the ICU. So as you see, the people ratio is quite low in our patients. It's only 150 over 115, and also we measure that the lung compliance also quite low. It's its average is only 22, and also the IOS level also is quite high, and also for the patients almost 72 of the patients requiring the intubation. So only 28 of the patients can survive from only the non-invasive mechanical ventilation. For the patients requiring the intubation, small parts of the patients also switch to the ECMO, and most of the patients requiring the prone position ventilation. Also, for our patients, 90% of the patients had severe ARDS, and the others complicated with the heart problems, including the anosmia and also acute heart injury. So we also routinely monitored the cardiac function, use the bedside TDE, the echo, the echocardiography to see how the cardiac function in the patients. And 20% of the patients had the AKI. So this kind of patient is quite sick in our ICUs. And also for the key points of the ventilation. So I mean our approach is the lung protective ventilation is quite important, and we should focus on this point. And also we try to prolong these patients as early as possible, and we evaluate the parameters we set for the ventilators regularly, and to change if the parameter is not appropriate for the patients. Also, we titrate the PEEP and the tidal volume based on the transpulmonary pressure, if possible, or the driving pressure. Keep the driving pressure less than 15, and the blood pressure less than 28. And actually, for our patients, we set the PEEP relatively lower compared to other ARDS patients. Almost most of the patients, we set the PEEP less than 10 centimeter water, and also the acute core pulmonary also common in these patients. I think it's induced by the severe hypoxemia, and the severe hypoxemia induced pulmonary hypertension. So this also quite important. If the severe acute core pulmonary will compromise the left ventricle function, and will induce the lower cut output. So if we give the enough oxygenation for these patients, this will be improved soon. Also, be careful of the lung recruitment maneuver. So actually, the highest people is quite low compared to the patients from other ARDS. So this patient is likely to have the pneumothorax. So if we set the high level of the PEEP. So here is the flow chart for the ventilation supports we prepared for our patients. So actually, we based on the PEEP ratio, like if the 20 to 30, or if the around 150 to 20. So if PEEP ratio is okay, and we start from the high flow nasal calibration first, and we just evaluate this works or not. If for 2 hours, if we based on the LOXI score. LOXI score is calculated from the respiratory rates and saturation, and also the the other parameters. So this is our flow chart for the patients. So, but if it doesn't work, we will switch to other models. Also, we try to, if for the non-invasive ventilation, so we set up the the IPAP around 8 to 12. EPAP is 5 to 8 centimeter, and also we observe for about 2 hours. So if we see the tidal volume, if the tidal volume is too high, and then we will intubate the patients. So I just mentioned that we try to prolong the patient as early as possible, even the patient still conscienceless. So if we intubated the patients, and also we try to perform the recruitment maneuver to see the patients have the capability. So, and also we adjusted the PEEP. So this I mentioned based on the driving pressure. So this is the flow chart that we set up for our patients. And for the ECMO, so if we tried all the the intervention for a while, the patient still the PEEP ratio still quite low for about 6 hours, and then we will try to switch to the ECMO. So actually, we have performed 15 ECMO already for our patients. So half of the patients from ECMO, around so this is the we have learned from our patients with the COVID-19. So I fully understand. So you what you are facing. So I'm happy to take any questions from you. So thank you for your attention.
Thank you, Peng, for this very insightful presentation. We will have a chance to ask questions and have a discussion on the topics you presented later on. Now, let's switch to another presentation. We have Professor Shish with us, and now, can I have the next presentation on the screen?
Yes.
Okay. So, can I ask?
Yes, but someone has to stop sharing their screen. My good friend Diong Peng has to stop sharing.
Yes.
Diong?
Hey, yes, it's me, yes.
Did you stop sharing your screen?
Yeah, okay. You want me to show my
sharing. Yeah.
Okay.
Which is beautiful, by the way, but
So now it's okay?
yeah, it should be.
Oh, so Professor Shish, can I ask you to deliver your talk, your short presentation right now?
So now you should have my screen. Can you see my screen?
Not yet.
Let me try again. Yes. Now you should have my screen.
Yeah, yes.
Good. So thanks for giving me this opportunity. It's a great pleasure to have the opportunity to discuss this, especially with my good friend. I was in one not long ago before it all started, Dion, and none of us could have guessed that this was coming. And I'd like to follow on the discussion that Professor Peng has started on mechanical ventilation, because as we are still struggling to know whether there would be I would say, a good antiviral strategy, and that does not appear clearly so far, we still have very much to rely on the symptomatic treatment, and mechanical ventilation plays a very important role in this, as highlighted by Professor Peng. And whereas we all understand that there might be some slight differences between ARDS from different etiology, we also have to remember that we are going to ventilate, and we now ventilate in my unit, patients with quite sick lungs. And I would say the strategy that we have developed and that is deployed over the country and by and large over the large Paris region is to follow recommendations that have been published quite recently in Annals of Intensive Care Medicine, which are formal guidelines for the management of respiratory distress syndrome, acute respiratory distress syndrome. And in this expert recommendation, we've came up in the end with 15, I would say, sound recommendation and a therapeutic algorithm regarding the management of this patient. And I'll be very interested to see whether Professor Peng would see some value to apply this algorithm, because what you told us in the past minutes is very much in line with what I'm going to propose in this algorithm. The first and probably most important thing is really to focus on delivering lung protective mechanical ventilation to these patients. And lung protective means seriously lung protecting. And I believe that when you see what's at the bottom part of the slide, you can see that following the initiation of invasive mechanical ventilation with sedation in the ICU, we are going to target a tidal volume of 6 milliliters per kilogram of predicted body weight. And we are going to tolerate acidosis as long as the pH is greater than 7.2. We don't care too much about the PaCO2. In Professor Peng's approach, you were speaking about the use of non-invasive ventilation and high-flow nasal oxygenation, which for us has not been used extensively so far because we are concerned about the potential for aerosolization of the virus with high-flow nasal oxygenation and non-invasive mechanical ventilation. And also because we know that in the most hypoxemic patient, it's going to be associated with a significant failure rate. And what I mean by significant is roughly 50%. The other thing is that we've been quite impressed to see that many of these patients do okay with, I would say, 3 to 5 liters per minute of oxygen. And I would say all of a sudden they require more oxygen. And these patients that have, I would say, subacute to acute deterioration of oxygenation are going to be quickly intubated. But for us, soon after intubation, we really focus on delivering safe mechanical ventilation with a tidal volume of 6 milliliters per kilogram of predicted body weight, a control of plateau pressure. And indeed, we will start with, I would say, reasonable PEEP level. And by reasonable, we mean they always have more than 5, but we don't go directly to the super PEEP that have been discussed and proposed by some authors. Obviously, when the patient gets more sick, then this is where we have to consider something more, I would say, personalized for the validation of PEEP level in this patient. And for this, what we do is to focus on the most severe patient, the patient that have a PF ratio lower than 200. These are the patients in which we are going to try to use higher PEEP level. And by higher, we mean that very often it's going to be beyond 10 or 12 centimeters of water, provided that we control the driving pressure and maintain the driving pressure below 13 to 14 at maximum. And obviously, most of these patients will have to be heavily sedated. That's, sorry, excuse me. They will have to be sedated quite heavily. And the next thing that will come is... Je suis en conférence. What we'll try to do is then to... sorry, as you can see, I'm clinical. So, what we try to do is to find the adequate PEEP level for this patient. And for this, what we do is to do a PEEP responsiveness test. And there are several ways to do it. Our approach is to increase PEEP from 5 to 15 and look at whether you have a significant increase in the pressure PF ratio together with stable PCO2 and stable compliance. If you have an increase in PF ratio greater than, I would say, 15 to 20%, while PCO2 remains stable or decrease and compliance remains stable or increase, we believe that these patients are PEEP responsive. And these are patients for which we are going to target higher PEEP level with a maximum plateau level, plateau pressure of 27 centimeters of water, while maintaining the driving pressure below 12 centimeters of water, even if this means further decrease in the tidal volume. This is what we call in this algorithm the maximal recruitment arm. Whereas patients that are not PEEP responders, patients where you don't see a significant increase in the PF ratio, or patient in which you can see that there is a sudden deterioration in PCO2 or compliance, these patients may not actually benefit from higher PEEP. And as Professor Peng told us in his experience, in this patient, we really target a lung protective approach with 6 ml per kilogram and more or less follow the PEEP FiO2 algorithms that have been proposed by several investigators before, like in the NH ARDS network. It's quite difficult actually to know whether such a strategy is going to be associated with, I would say, whether this strategy is going to be associated with an improvement in survival. But this is something that we are going to test in a randomized controlled trial that's called Pesetas, where patients that will be deemed responsive to an increase in PEEP will be treated like this, and patients that have no potential for lung recruitment will be rather kept on the protective set. Finally, I'd like to insist on one thing before we discuss ECMO, is that when the patient really gets severe, it's really important that we apply the recommendation, and the recommendations are to keep this patient on neuromuscular blocking agents and to use prone positioning in this patient. I cannot stress this enough. This is probably one of the most important part of lung protection today in these patients. And in our experience so far, I would say 80% of the patients have received prone positioning, and we have seen less need for ECMO in these patients. So these were the thing that I wanted to share with you, and I'll be very happy to discuss this with all of our colleagues and answer questions if there are questions later on.
Thank you, Professor Sisch, for sharing this presentation with us. Since we in Poland still are on the rising tide, we still don't have a lot of experience with those patients because the cases are quite limited for now, luckily for us. I think we will move straight to the questions and answers part. So I would like to ask the speakers to try to type some of the answers for our chat module. And I will also approach some of all of you directly with the questions which were sent to me. So I think we will start with Professor Peng, if everyone's okay with this, because I have noticed that there was a very high use of antimicrobials in your patient populations in Wuhan. Professor Peng, please tell me, did you start the antimicrobials at admission or when a bacterial superinfection was suspected or diagnosed? When did you start them and for what reasons?
So actually, most of the antibiotics were used prior to ICU admission, and actually, personally, I don't know why they used the antibiotics initially. So actually, in ICU, we will use the antibiotics if we have the evidence. The patient have the secondary infection. We have the evidence suggests that we have the increased level of the polycystomia, and also we have the culture to show the patient have the have the from the blood from the BLL, and we have the positive culture result, and then we will try to use the antibiotics for the patients. So initially, and if the patient stay in ICU for more than at least for more than 10 days for the intubation, and we will try to use the antibiotics for the prophylaxis, but only only in the for the if we intubate the patient for at least for 1 week, and then we will use the antibiotics for the prophylaxis. So this is the for the we use this is the indication we use the antibiotics in ICUs. But usually we depend on the situation. If we have evidence, definitely we will use the antibiotics. So if the patient admitted in the ICU is early stage, without any evidence of the secondary infection, so we won't use the antibiotics for the patients.
Thank you very much. And now I have a question for Professor Shish. There is a little confusion about the latest COVID-19 surviving sepsis campaign guidelines, because the recommendation 38 clearly states that giving antimicrobials is beneficial over not giving antimicrobials, even in the case of a lack of a proof of a bacterial infection. Can you comment on this, on the rationale of this recommendation? Professor Shish, we can't hear you.
I was saying that the rationale for this recommendation is admittedly quite weak. And I think that this can be, I would say, adjusted based on your attitude to diagnose superinfection in this patient. Our experience is that the superinfection is not that common. It's probably less common than with flu. And what we tend to do is to use PCT on ICU admission, and in patients that have a negative PCT, we don't give them antibiotics. We may give them antibiotics if the PCT is high while waiting for the results of the culture, but if the culture is negative, we will stop antibiotics as well. So I believe that indeed this recommendation 38 is probably going to fuel a lot of controversy, and I would recommend, I don't want to, obviously, I don't want to underestimate the work that has been done and the importance of these pandemics. But we should not lose our brain and our habits of being good doctors. And being a good doctor means you should give antibiotics when you have a bacterial infection, okay? Not because you fear bacterial infection. It's not because you don't have a potent antiviral treatment that you should do anything. And the most important thing is to keep, doing the right thing and apply some physiology at the bedside and buy time. And it's going to take time. Most of these patients require, and I'm sure that Professor Peng will confirm it, they require, 10 days, 14 days, sometimes up to 3 weeks of mechanical ventilation. Sometimes when you start to taper sedation, they worsen again. So no systematic antibiotic, I would say.
And in my personal opinion, the heavy workload of the procedure might limit the availability of proper ICU treatment for other patients. But if you had to name a patient phenotype suitable for ECMO with COVID-19, who would it be? What kind of patient, in your opinion, is likely to benefit from VV ECMO therapy?
I'd like to add something. Is in our experience, when you follow, and again, we don't have seen as many patients as Professor Peng today, but we've already done like 50. And in our experience, the number of patients that need ECMO is not that high. When you follow the recommendation and when you actually set the right PEEP level, when you use prone positioning early on, the number of patients that get the ECMO criteria is not that high.
Okay, so could you please comment on the Oklahoma Heart Institute's prediction score for VV ECMO in COVID-19? Do you think that this might be a feasible tool for identifying the right patient?
I would say I would use the REST score that has been developed by I would say the French and the NZICs. But again, the algorithm that I presented to you, I think makes a lot of sense because it's a stepwise approach, and it does not lead you to have a patient on ECMO that hasn't been in front positioning before. And I don't really believe that many patients should go on ECMO directly. I think that so far we haven't seen what we've seen, for instance, with H1N1 flu, where you see sometimes patients where from day one you realize that their compliance is very, very, very low, and that the proportion of potentially ventilable lung is really small.
Thank you. And now I would like to ask Professor Ovchuk to give a short comment.
Thank you. I have two questions. The first one is to Professor Shish. Let's go back to Surviving Sepsis campaign guidelines and the role of nitric oxide, because it may be really attractive proposal for some individuals, but I'm afraid that there will be problems with equipment in some places. So what's about prostacyclin and Ventavis instead of nitric oxide?
So the strength of recommendation for nitric oxide as well as from prostacyclin is going to be very low. If you have access to nitric oxide as a gas, clearly the efficiency in terms of improving gas exchange is, I would say, more documented than prostacyclin. And I actually believe that we don't have the answer. I don't know whether nitric oxide is useful or not for ARDS patients, because all the studies that have been done, I would say, before the era of lung protective ventilation. The latest PRCTs published by Taylor and colleagues in 2004, if I remember, or 2010, the tidal volume was 10 milliliters per kilogram. So if you use a tidal volume of 10 milliliters per kilogram, nothing is going to rescue you. So if you have access to nitric oxide, if your patient is severely hypoxemic after muscle relaxation, after being put on prone position, you can give it a try. And even if you don't really have the apparatus to monitor, just using the smallest dose available may actually help your patient, especially if your patient have, I would say, some indication of right ventricular dysfunction or right ventricular failure.
Thank you. And the next question, maybe to everybody, is the question about high flow nasal cannula, because it may be controversial. It's advised, but I'm afraid that it is necessary to perform this procedure in specially prepared rooms. So what's your opinion in normal condition?
So actually, we are also concerned about this issue using the high flow lateral cannulation. So I prefer using this technique in the environment with the negative pressure, because we compare the virus level using in the ICU environment. One is with the just the regular opening the window. The other is with the negative pressure. So for the ICU with only opening the window. So sometimes we found the positive virus nearby the machine when we using the high flow technique. So this is the I don't think it's the safe way for the for this technique using in the routine environment in the ICU. So this is the we used. So we usually use this technique in the ICU with the negative pressure environment. So this is the our experience. We use the high flow nasal cannulation, and also I don't think it's this technique will because in our ICUs only small part of the patients benefit from the high flow. Most of the patients I just mentioned the 70% of the patients requiring intubation in our ICUs. Only 20% of the patients receiving the non-invasive ventilation. But a quite small part of the patients benefit from the high flow the technique.
Okay, thank you very much. We also have some participants outside the, let's say, ICU anesthesia environment. We have some surgeons, and there is one question from them. How should you work with the COVID positive patients in the theater? I mean, do you have any recommendations regarding safe conduct of any surgical procedure? I mean, apart from strictly anesthesiological recommendations. I think Professor Peng would be ideal to start answering this question.
So actually, in my hospital, we have performed 80 cases with the COVID-19 in the operations in the OR, and we opened a room with the negative pressure. So this is quite important for the for all the medical staff there, and also for the personal protection depends on the procedures. So if the procedures, I mean, if they have some procedures related to the airborne generation, airborne protection, probably they will use the highest personal protection equipment. So it depends on the procedures. So so far, no any medical professionals working in the OR infected for the patients with the COVID-19.
Okay, Professor Shish, can you share some information regarding this topic with us?
For students, you mean?
No, the perioperative setting. I mean, COVID-19 patients undergoing procedure, usually emergency.
Okay, so for now, I would say we have absolutely no experience because all of our COVID positive patients have not needed surgery. But what's planned, for now, they really behave like medical patients and none of them did require any surgery. If that was to happen, at least there's one thing where there's one place in the hospital where they know something about infection control, and this is the OR. And I'm not actually worried that much about that aspect. The aspect that worries us much more is when patients are discharged from the ICU and it can be extubated. Some of them are still, I would say potentially contagious, and we have to send them to COVID plus environments where training for isolation procedure may not be as strong.
Mm-hmm.
That's almost. Yep.
Mm-hmm. But that's an excellent topic for further discussion, because we actually had one patient who was ventilated for 12 days. Then his clinical condition improved and we decided to run the RT-CPRs and we got 2 negative results. So we decided to get him out of the COVID positive environment. And now, do you believe this also should be a protocolized procedure? Because we actually do not have any experience nor guidelines on that. So how would you extract a patient still on a ventilator from a COVID positive environment? Do you have any recommendations for us? How would you do this?
Professor Peng, you have the most important experience.
For the, for the patients, could you say again? So,
do you have a protocol for extracting patients who are no longer in need of mechanical ventilations and are COVID negative? So, I mean, when do you make a decision to consider the patient no longer dangerous to the healthcare staff or no more contagious? Do you have a protocol for saying that this patient is no longer a threat to the healthcare professionals or other patients?
So at least we need to measure the the PCR for 3 times. If all 3 times negative, and the patient without any symptoms, and also the CT chest improved a lot, and then we will consider the patients as the relatively low contagious to others. So, if possible, we will also follow the the antibody. If the patients have the the antibody is the IgG positive, probably is okay. Yeah, but if the consecutive 3 times negative, so it's for the patients, without any problem of the transmission.
Okay.
Transmitted, yeah.
So what you're saying is that we should carefully monitor the clinical symptoms,
Right.
imaging studies, and finally perform the RT-PCR or the antibodies, right? So you should have
RT-PCR at least 3 times, negative 3 times. Mm.
Okay, 3,
Yeah.
right?
Yes, 3 times. Yeah.
Okay, all right. And then this patient is declared to be non-contagious anymore.
And also we need to quarantine for the patients at least 2 weeks, and then check again, and then still negative. That's okay.
Okay.
Yeah.
So we have touched the subject of imaging studies. What's your opinion on the role of chest CT scans as screening tool or treatment monitoring? Do we really need a chest CT scan to monitor the disease? Or perhaps lung ultrasound might be a sufficient tool to do that. Okay, Professor Shish, can you comment on that too?
I absolutely agree. I don't think it makes any sense to put this patient to the CT scan neither for diagnostics. Okay, the bugs are really small. They show better on PCR than on CT. You will find ground glass opacities, yes, as in many other diseases. It's very, very, very common in patients with COVID-19 infection. And it does not really help you to set the ventilator, especially if you think what you're going to do is to set the most protective approach, So I would not take the risk for patient deterioration and dissemination of infection. We need time. Make sure that we adapt our capacity to face the number of patients that we get, because clearly, when these patients are in your ICU for 2 or 3 weeks on mechanical ventilation, you are going to face a problem in capacity. And this is really the thing you want to avoid. So don't do anything silly.
Speaking of supportive therapy, we have a question from Professor Ovchuk regarding the CRT and AKI. Professor Ovchuk, can you comment on that?
Yes, I would like to ask about the acute kidney injury incidence, especially in China, and the role of CRT, the mode of this therapy, and the role in patients, not oliguric patients with cytokine storm.
So let's say, Professor Peng, I think you are the perfect person to answer this question.
So actually, in my ICU, about around 25% of the patients develop the AKI, and of these patients with AKI, and half of these AKI patients requiring the RT therapy. So I mean the proportion almost similar to the population in other ICU patients. So I fully understand probably the patients in Europe, you have the high instance of the AKI, and I heard the news, but I don't know why is the patient have the high instance of AKI in the different populations.
I have just received a message that Professor Shish is going to have to leave us. So, Professor Shish, can you quickly comment on the role of CRT, in your opinion, in treating the COVID-19 patients?
We see, I would say 20% of the patients that develop acute kidney injury. Many of them because they come profoundly dehydrated after high degree fever for a long time and high minute ventilation for a long time. For now, I would say that 15 to 20% of these patients will require extrarenal replacement therapy, but it's nowhere near the 50% that we've seen and heard somewhere in the literature. For us, it's more 15 to 20% and no more.
Thank you.
I'm sorry, I have to go. We have crisis management meeting.
We understand. Thank you for your participation, and see you, and good luck, sir.
Bye-bye.
Yeah.
Thank you.
Yeah, take care. Take care.
Bye-bye.
Thank you very much.
Let's go on then, and we have another question from our participants. One of our colleagues is concerned about a situation which we hopefully won't face, but let's imagine that in a couple of weeks we will have all our ventilators and ECMOs busy and running, and the patients will be still coming towards our doors. Now, what do you think might be a reasonable approach? We have already discussed this a bit. So a lottery might be one answer, but do you think that we should be ready for such difficult times? Do you think that we can prepare for that? Or is it just going to be a catastrophe? Professor Peng, did China reach this stage, or did you manage to avoid such hard and difficult decisions?
So it's the actually this is the difficult approach, and also in the early stage of the outbreak in Wuhan, and also we've faced the lack of the medical resources, and also we try to triage these patients and tell them, okay, you should stay at home, you should stay in the temporary shuttle, and you should if you have some problem, you just call us and try to avoid rush to the hospital, and also we have a very difficult period for almost 10 days. A lot of the patients rush to the hospital, and they try to think of the medical care, but without any. Actually, we we haven't enough the space for the patients. So this is also the the problem induced the the serious transmission in the hospital, because all the rush to the hospital, and so this is the I mean, if the time could go back, and I would ask the patients, first, so we try to have the consultation by the phone or by the telemedicine, and try to avoid them to come to hospital. So this is a very critical situation. So try to avoid the patient rush to the hospital, and also for the hospital, we try to open more medical beds, try to open more the ICU beds for the patients to prepare the outbreak. So this is the we did before, but unfortunately in the at least 10 days we failed, and this is a big issue to induce the huge number infected in the hospital. So this is I mean, we try to avoid that the patient try to avoid patient to the hospital, rush to the hospital. So this is the very important for the the lessons we learned before.
I understand. And now we have a question from our participants regarding the routine use of neuromuscular blocking agents. Now, we have all been there. We remember the ancient times in critical care where everyone was given these drugs, and now it seems that it might be feasible to take a big step forward. Now, what's your opinion on administering these drugs for the sake of the healthcare professionals' safety? Because there are no clear indications besides the acute period, but now let's face it, some of us will try to protect themselves by limiting the exposure risk. Professor Pang, any comments on the issue of neuromuscular blockades?
So actually, for the trigger intubation, and we fully polarize the patients, and also we try to make all this process smoothly. So this is quite important to make the patient comfortable, make all the physician comfortable during this procedure, and we prepare a very good protection. We wear the hood during the procedure. I mean, this is for the trachea intubation, but for the mechanical ventilation, we use much more muscular relaxants for the patients, because these patients have the severe problem, the lung problem, and if we try to adjust the PEEP, I just mentioned the PEEP, we said is relatively lower compared to the other ARDS patients. So if we increase the PEEP, and actually the blood pressure increased more, it means the driving pressure will increase, and in this situation we consider the patient so have the compliance problem, and then we will polarize the patients, and also of course we prolong the patients, and for at least for 1 day, and to see what happened in the patients. So this is the we used for the mechanical ventilation.
Okay, thank you very much. And we have quite a lot of questions regarding the monitoring of severity of disease basing on immunological markers. Now, I think that CRP is not our best option, and of course PCT also. So do you have any insight on the possible role of other biomarkers which could help us monitor the progression or regression of the disease? Any thoughts here, Professor Pang?
So actually, we routinely measured the IL-6 level for all these patients. And also, we found if the patients with the high IL-6 level, also with the poor outcome. Also, we monitored the lung compliance. If in the first day of the intubation, if we found the initially the compliance level is lower, it also indicated the poor outcome for the patients.
Professor Ovchuk would like to add a comment.
I would like to ask about safe prone positioning, because it's a recommended method for these patients. I think that Professor Peng has huge experience in safe positioning, because it may be dangerous both for patient and for our staff because of disconnection of circuit, extubation, etc.
So of course, we should have the detailed protocol how to perform the prone position, and at least we prepare 3 personnel for this procedure for the prone position, and also if the patients have the severe hypotension, I mean requiring the dose of the norepinephrine more than 0.2 microgram per kilo per minute. And then we think this patient probably is the hemodynamic unstable. And we won't prone this kind of the patient with the hemodynamic unstable. And otherwise, if we prepare well for the for the prone position, and we keep all the line, all the tubing, everything's okay. So this won't a big problem for us, because we have a lot of the experience to before just before the outbreak of the COVID-19. We performed a huge number of the prone position in our ICUs. I mean, this is not a big issue, for the safety. But okay, be careful for the hemodynamic unstable. So if the patient have the hypertension, low blood pressure, so be careful about that.
Okay.
What's about pregnant females, especially in late phase of pregnancy?
Yeah, actually, I haven't seen these patients with the I haven't seen the pregnant lady with the infection of the COVID-19, or also with the ARDS, and we need to prone this patients. So if for the pregnant lady, so I won't prone these patients.
Okay. And when we discuss the issues of potential problems and pitfalls of patients' positioning, I think we should also mention the possibility that CPR should be implemented. Now, any comments on that? I think it's a good question for Professor Pang. Did you have a chance to resuscitate, to perform cardiopulmonary resuscitation in a COVID-19 positive patient? And can you give us provide us with any details?
So actually we had it before, and of course the safety is still the safety is quite is the top of priority for our medical professionals. So so this is the issue for safety, which we try to avoid the transmission from the patients during the procedure. And also, I mean, these patients, most of the patients have the cardiac arrest is due to the severe hypoxemia. So if we improve the oxygenation, the patient is easily to recover from the cardiac arrest. So this is the point for this patient with the COVID-19. I mean, we had this problem with the sudden cardiac arrest because this patient with a long time severe hypoxemia.
Okay, so the general impression is that even if you attempt a CPR, it would likely be unsuccessful, right?
Yeah, of course. So it depends on especially the patients admitted in the ICU with the cardiac arrest. So for this kind of patients, it's not easy to recover this patient because I don't know how long the patient have the severe hypoxemia already. So it depends. So if the patients, sometimes we found the patients in the ICU also had cardiac arrest, but this patient is easily to recover. Depends on the situation.
But can you give us any data, preliminary data, on the results of CPRs in these patients, or they are unavailable right now?
So actually, in my ICU, we took the patients with the cardiac arrest, when the patient is admitted in the ICU. So for this kind of patients, the outcome is always not good. Always complicated with the neural damage. Is the such an issue. But if the patients had the cardiac arrest in the ICU already, and this patient always is easily to recover, is also without any neurological complications.
Thank you for this. And Professor Ovchuk would like to add something.
I hope it will never happen, but I'm afraid that there will be some places with the shortage of ventilators. So what's your impressions about the usage of one ventilators to two patients?
Okay. So does anybody have any experience? Because we had some data on this subject. I think there is a company, there are a few companies trying to implement such solutions.
So actually, we are also concerned about this issue, and we use the filter when we use the ventilation for the patients, and I'm not sure it's enough. It's only a filter inside. So this is the issue we concerned, but we don't know how to sort it out for this problem.
With some insight on the role of steroids in managing COVID-19, because in my opinion, the role is quite limited. Do you agree?
So actually, this is also a controversial issue, and based on the previous report, the steroids doesn't work for the virus pneumonia patients, and also guideline issued in China, and also is the limited use for the steroids. It's only for if the patients develop the patient situation deteriorated rapidly, such as the PFO ratio going down rapidly, such as the patient the chest CT huge significant changes with 1 day or with a couple of days, and then we are recommend you try the small dose of the corticosteroids is around 1 ml per kilo, per day, for 3 to 5 days. So this is the quite minimal, quite low dose steroids for the patients. Also, if the patients had complicated with the septic shock, of course, we use the steroids for the patients. But otherwise, we should be cautious for the steroids use for our patients.
Okay, so I think that we have discussed most of the topics we planned to. So I think that it's time to end our meeting. I would really like to express my deepest gratitude to all our experts. Thank you very much for your valuable insight, for your time. I hope that together we will overcome this pandemic situation and we will have a chance to meet in a couple of weeks, maybe months, to discuss all the things that we have learned. And now I would like to give the final word to Professor Owczuk. So thank you very much.
I really appreciate your involvement in our education, and I would like to appreciate our audience who received a huge dose of knowledge. And I would like to say, as it's a slogan, but it's very important now, take care. Take care. Bye.
Thank you very much.
Okay, thank you. Okay, take care. Take care.
Bye-bye.
Bye.
Bye.